Welcome to Finding Your People, Issues in Patient Identification, Recruitment, and Referral, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. It's now my pleasure to introduce our moderator for today's webinar, Dr. Al Su. A member of the HAH Users Group leadership team, Dr. Su has been a national leader of the hospital at home movement in the United States during the last decade, and he is today the director of Mount Sinai at Home, as well as professor and chair emeritus of the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Su also holds an appointment at the Geriatric Research, Education, and Clinical Center, the GREC, at the James J. Peters Veteran Affairs Medical Center, which has its own hospital and home program. Please take it away, Dr. Su.
Thank you, John, and welcome to today's webinar. I am pleased to moderate today on behalf of the Hospital at Home Users Group, that I've had the privilege of being part of, and leading over the last several years, along with Bruce Leff at Hopkins, Linda DeSherry at Mount Sinai, and David Levine at Brigham and Women's Hospital. This slide shows us our website. Much of the materials, that we've created as part of the users group are available on the website, particularly under the Technical Assistance Center provided in the website. Under the TA Center on the website, you will find a list of the webinars, that we have hosted since January as part of this series. Today's seminar is the 9th seminar. You will see, on the slide, a number of other seminars that we have hosted. All the materials and slide decks, as well as the recording, is on the website. As I've mentioned, this is our 9th webinar. We will be having monthly webinars for the next several months. We plan on 2 webinars coming soon, one on staffing and one on payment and reimbursement coming in the next 2 months. So please stay tuned for the exact dates and time and registration information for those future webinars. Additionally, please chat to us or put into your Q&A topics that you would like to see covered in these future webinars. They provide valuable input to us in terms of selecting topics, and indeed today's topic flows from some of those requests that we've received in chats on previous webinars. So today, as John mentioned, we will be talking about finding your people, issues in patient identification, recruitment, and referral. This is in many ways a companion webinar to episode 3 in our series, which focused on finding your patients and provided you with background from 2 of our users group organizations, Mount Sinai and Presbyterian in New Mexico, about how patients were identified, for our programs. Today's webinar is complementary to that webinar, and you will find, things that are similar in terms of approaches to those 2 other organizations, and things that are different, between these 4 programs, we hope to give you, a good understanding of how appropriate patients can be found, recruited, and referred for hospital at home. Our 2 speakers today are first Colleen Hole, who is Vice President for Clinical Integration and Population Health and Chief Nurse Executive at Atrium Health. She will tell you a little bit about Atrium as an organization. She is based in North Carolina. And our second speaker is Michelle Grinman. Michelle is in Canada. She is a physician and on the faculty at the University of Calgary and is the Seniors Palliative and Continuing Medical Care Lead in the Calgary Zone for Alberta Health Services. She is based in Calgary, in Canada. Our two speakers, have no significant disclosures and conflicts today. And with that, I'm going to turn it over to our first speaker, who is Colleen.
Good afternoon, everyone. It's really a pleasure to be here, having spent, like many of you, about 14 months and many longer. There aren't many topics I'm more excited about or passionate about, so the opportunity to speak is truly an honor. And I'll start with a disclaimer. We haven't figured it out yet. We've not fully figured out the best way to find our people, if you will. But I'm happy to share what we've learned and what has worked for us. But I would say, like many of you, we refine as we go. So Atrium Health, it's a large organization, as Al said, primarily located in North Carolina, but we spread down into Georgia as well. And with the size comes a lot of opportunity, frankly, some resources, but obvious complexity. So it's two sides of the same coin. Trying to standardize work, build consistent workflows, challenging, I think, the bigger that you are. So our hospital at home program really was born out of a crisis, like some of the rest of you. We launched in March of 2020 after really about 10 days of planning, about 7 folks, really with just 2 in-person meetings, the rest virtual. We put together what we at that time called the COVID-19 virtual hospital. And our sole purpose for being was really to assure inpatient bed capacity. Our greatest fears were that we would need literally double what we already had. Thankfully, that was never realized, but we were prepared to contribute to a pretty big lift, including field hospitals, to increase our bed capacity. In addition, we wanted to keep an eye on folks who were positive, but not yet very ill, and touch them frequently enough to know when they were getting sick or needed an intervention. I've said many times, I think the greatest symptoms beyond clinical for COVID patients is fear and anxiety. So frequent touches help these patients feel like they're not alone, someone's looking out for me. And we do believe, we've got evidence to show that we were able to decrease community spread by constantly interacting with these patients. So Census Trends in the beginning, like most places, we were nowhere near peak. In fact, started in March, but May 5th through July 6th, we were actually able to close this acute care piece for a time. The census dropped and we had hospital capacity. But then starting in September, and these are unique patients, the census started to climb almost at a scary pace, like many of you have experienced, to our peak unique number of patients in January was 523, and a peak census on one given day was 130. So what started as we can handle this quickly became anxiety provoking, but we did it. And just as precipitously as it climbed, it fell back off. So our scope of services in what we then called CVH acute, and I failed to mention, we had another portion called CVH observation, which was really any patient who was positive with no symptoms or mild symptoms, and that was literally RN connectivity, no in-home interventions at all. But this is the piece that later became our Atrium Health Hospital at Home. Much of these services will look familiar to most of your programs: remote patient monitoring for vital signs, oxygen saturation, 24/7 telephonic assessment and monitoring. We use MIH, or community paramedicine, for our in-home care. But at peak, before and after, we did pull in 9 additional RNs from our home health agency to supplement that team. Daily virtual visits with the provider, and like many of you, IV fluids, IV antibiotics, oxygen treatment, respiratory therapies, etc., EKG, imaging, and labs. And with COVID only, as I mentioned, that's how we really got our launch. We used a modified DS-Crib 65, which assigns a score. And based on that score, which loosely was mild, moderate, and severe symptoms, that was really our algorithm to determine where to place patients. So when we think about how do we find our patients, it was really easy in the beginning, frankly. It was all COVID, and all we really needed to do was assure that we placed the patient appropriately within our system. So brick and mortar, that was our hope for, not where we wanted to send patients, but obviously quickly we knew who those were. little bit of discerning between mild and moderate, as we know, escalation and de-escalation, but it was pretty easy by the criteria we developed, which of those places the patient would be. I won't go into a lot of detail here, but we used a decade-long process that we call physician connection line, and it's really our intake process into Atrium Health, initially from outside of our system for patients that needed to transfer in. So it was really a triage and almost a gatekeeper function for us to make sure that everything about the patient was fully vetted to make sure that this was the right level of care, and assigned what we called a quarterback, hospital at home quarterback, that had the big picture across all of our facilities, all of our testing sites, and was able to triage more appropriately from that seat than any one facility would have been able to. Mobile medicine is involved in that conversation. We wanted to make sure that even though the patient might be eligible for placement, maybe they lived on the outskirts of our entire footprint, and assigning that patient would mean spending half of the day in the vehicle. So sometimes that was a selection criteria where the patient lived. So very generally, and this may look familiar to most of you, we had eligibility criteria that we chose to put into 3 buckets. Clinical factors, which are probably the easiest, frankly. We took a patient at no greater than 4 liters of O2 per nasal cannula, but occasionally we would end up at 6 and 7, as long as they were de-escalating in their need. We would take those patients, but generally no more than 4 liters, stable vital signs, not needing any more than Q6 frequently vital signs, and not anticipating to need CT scan, MRI, or any interventional procedure. And then really, really important, and we spend time on this, is social determinant factors. Making sure the patient has a working phone number, that we have a correct address, as they may be staying with a relative during their illness, verifying that, making sure there's someone in the home to support the patient with ADLs, groceries, meds, ambulation, and really harder to assess virtually, but is that living environment safe? So we've got criteria by which we evaluate that. Sometimes the patient doesn't always tell all in those interviews, but it's discerned on the first visit into the home through another assessment to just make sure that home is safe. And then patient factors about the patient themselves. They may have some early onset dementia, but can they understand the directions? And if not, is there someone that can help them in that? And though they may be confused, is this new confusion related to hypoxia, not their baseline confusion? And are they able to comply with the devices or have someone in the home that can help them do so? In addition to these, obviously we had, once we got past COVID, some clinically specific criteria around various diseases. I will say we continue to refine that list as we learn more about the factors that actually matter. And like most of you, we have some exclusion criteria. We do adapt these as we go along. I won't read to you, but any condition for which a brick and mortar stay is more appropriate, obviously. Some of these domestic violence screens would probably contribute to that discussion on social determinants. We have not accepted patients in skilled facilities, group homes, SNFs, assisted living, or patients who leave the ED against medical advice or inpatient against medical advice. We currently are not caring for pregnant patients, but I do anticipate that we will, as well as pediatrics. Now, I will say we have a pediatric arm of this, but not cared for under our program specifically. So that was the easy part, right? COVID. The inpatient facilities got accustomed to what we were doing. They were desperate to relieve the capacity concerns, so we were front of mind, out of the gate, ED or inpatient. Oh my goodness, it's COVID. If this is clinically appropriate and safe, we can send the patient to hospital at home. So really early on, we didn't have a lot of difficulty identifying patients. It was one clinical condition, and it was an urgency really across all of our facilities from a capacity perspective. But here the real work begins. So thankfully, at least in our market, we're seeing a steady decline, fewer hospitalizations, fewer deaths around COVID, and now we're ready to begin what I call the really great work for our future. And so this is not an exhaustive list, but these are the conditions, I'm sure it will look familiar, and not all of the conditions, but in general, we look at chronic condition exacerbations and largely around those 4 with some others, and then acute episodic conditions that are appropriate clinically for a hospital at home program. I will mention we started and ran a whole year as an outpatient entity. We are now stood up as an inpatient entity around the waiver, which I'll talk about in just a second. But honed in really on heart failure, we had already done a lot of collaborative work utilizing our community paramedicine program that existed before COVID. And it was just a very natural connection for hospital at home. And you will also notice I interchangeably say virtual hospital and hospital at home. We are officially, as of last September, hospital at home, and we took the COVID part off in anticipation of what I just shared. So how do we find our people? This is an ongoing challenge. That's why we're having this webinar. As I said, COVID was almost a slam dunk. There was such desperation to get these folks out or not admit them in the first place. But we have a number of things, and a couple others I'll mention. One, nurse navigator. Though we don't have a nurse navigator for our program as a whole, which personally I think could be the linchpin for us, but we do have nurse navigators within our hospitalist group as well as our cardiology service. So they help us keep an eye out for potential patients. In addition, we have a very robust case management, both hospital and ambulatory case management folks who are also discharge planners in some cases. They have a list of everyone, clinical condition, what day of stay they are in, a whole bunch of factors that help us discern, and they are constantly working the list, as they say. Who among these might be safe to be discharged? Who's in the ED that might be safe to avoid the admission in the first place? ED is a place we spend a lot of time. And again, we're large and under the waiver in 6 of our facilities. So while we are one system, it's safe to say we have 6 different cultures in those waiver facilities, 6 different sets of resources. So finding a champion on the inside, both ED and inpatient, I think is one of the critical factors. So we've been blessed with some very engaged, both physician and administrative champions who help us work from their angle. What processes would work best? What further education do we need? How do we better help folks understand what this is and the benefit for getting the patients into the program? We've also implemented, not as part of hospital at home per se, but we're riding the back of an initiative called Progression of Care. It's essentially your IDR interdisciplinary rounds, but making that far more robust since COVID. It's nurses, physicians, and some of our disciplines on rounds, making hospital at home front of mind so that they're thinking about not just SNF or discharge with home health, but what patients might be appropriate rather than just extending that length of stay. And then forever, maybe till the end of time, ongoing education to our providers, our nurses, and all of the other disciplines, keeping them continually engaged with job aids and meetings and anything else that will work. So we attend staff meetings, just helping people learn about and frankly appreciate and value what we can do for hospital at home. A few other things we started more recently. We've got our hospitalist nocturnists involved in looking across the whole hospitalist group panel, who among them might be appropriate. And then expanding the role of our 24/7 RNs to also pair up with those hospitalist group physicians to help together decide. And changing the RN role a little bit to be more of a pull than a sit back and wait to receive patients. And in that, I'm talking about the transition where nurses actually virtually engage with the patient around the education, teaching them how to use their monitoring devices, et cetera. All of that to ease the burden on the inpatient side, because quite frankly, it's easier in most cases to discharge a patient from the ED to, not discharge, but transfer upstairs to inpatient than it is to transfer to hospital at home. There's more to do. Frankly, if a nurse is discharging a patient, they do discharge instructions and they're gone. we actually have to do an RN to RN handoff report and a whole lot of other steps. So we're trying to put some of that burden on our hospital at home nurses. We're also going to do a video that the patient can view before they leave. And part of our transfer process is assuring the patient understands they have the option to stay in brick and mortar. So the video will cover some of those things. So hopefully another layer of assuring that we have the right patients. I think almost all of you are under the CMS waiver, but just very quickly what that meant for us. We did publish, back in the fall in the Annals of Internal Medicine, and our Harvard and Hopkins colleagues read it. I think they're probably on the call. It's been great to interface with those folks, but received a call to say, hey, it looks like CMS is ready to move on this. Where are you all in this process? And we were not quite ready to sign up at that moment, but got us really thinking and planning for, as I mentioned, converting from an outpatient to an inpatient entity and all that comes with that. So we spent the next several months, we were approved in December, but didn't implement until March, mostly because we were handling that capacity crisis, but began to work on conditions of participation, writing some of our policies that needed to look a little different. But this has been game-changing for our system. I think it opened the door to something that we might have put to rest when COVID fell off, and started a series of meetings till the end of time, perhaps, to plan how to do this. So this is traditional large health systems, plan, paralysis, analysis. The COVID was horrific for all of us. I'm not sure we would be here today had it not happened. So as I mentioned, we started with 3 waiver facilities. We're now up to 6. We had to spend some time with the state licensure and CON folks, but they ended up waiving their process for us. And I'll mention at the bottom, one of the best reasons I think for participating is to have the ear of CMS as they look at our data and we interact. We're hopeful that all of the learnings of all of us will help inform future policy. So while it is wonderful, it does create, it's not a barrier at all, but it's another piece through which we have been asked to screen our patients. So I mentioned clinical factors, social determinant factors, patient factors, but at this point, our system is asking us to also go through payers. So we obviously, all Medicare fee-for-service, Medicaid, self-funded patients, and only one MA plan in our market has agreed to cover this. So that is our focus from the emergency department. From inpatient, really, it's all payers because there's still great reason, decreased length of stay. But we struggle with a little bit is clinicians, and I am one, we don't want to think about payer when we determine which level of care a patient could go to. I will say, obviously, it is not less or better. It is appropriate care for those patients. Keeping the patient in brick and mortar is not or worse, but we look forward to the day when this is the way we do healthcare and that we can to route every eligible patient to this model. We did, thankfully, just recently published our second paper in the Annals of Internal Medicine just last week. It's a short paper if you want to read it, but essentially we're trying to figure out what is the evidence to help inform our selection. So very timely that I was asked to present here. Essentially, we found that oxygen saturation particularly and comorbid conditions were a reliable indicator of appropriateness. So it's probably well, no kidding, Colleen, but the paper, and obviously you cannot read that tiny print, was able to show that indeed that is true. So our selection criteria around 4 liters of oxygen per nasal cannula, for example, and our scoring of chronic conditions, that was all helpful. Challenges, I won't go through most of this, but we worked virtually the whole time. It engaged all silos, traditional silos across our health system. We are a Cerner clinical shop and an Epic everything else. That was a challenge. Other priorities, and of course, as I've mentioned, the payment model. We've learned a lot. We believe virtual care is care and can be very personal. We can't assume that certain populations won't embrace it, particularly older patients. We found that not to be true at all. And we were pleased to see that we can be fast and nimble when we need to be, as this crisis required us to be. And sarcastically, silo busting is actually really fun. and it's easier to do the work when nobody cares who gets the credit. And I won't read to you, but I will tell you this was a couple, a real couple, elderly. The wife had dementia before COVID and did not survive, but much, much longer letter than this from the daughter of this couple who said, it was so wonderful. My dad had not done well in brick and mortar hospitalizations previously, and he's back to his normal life. We've lost our mom, but they were able to be together when she passed. And we have countless stories like this that tell us this is the right work as soon as the American healthcare system and maybe the Canadian healthcare system catches up. So I'll turn it over to my colleague, Michelle Grimman, to talk about her program.
Thank you, Colleen. So I was asked to talk a little bit about the Canadian perspective. We are a single payer system, so a little bit different in the way that we maybe approach our healthcare system. And the other reason I think that I was chosen to talk about this is because our program has been around since 2018. And so some of the, we expanded for COVID, but the patient selection criteria and the way that, the challenges that we've had in terms of choosing our patients, it started from 2018, and then we've sort of adapted as we go along. So I'll try to kind of highlight some of the things that we've learned along the way. So I'll talk a little bit about what our program is like here in Calgary, a little bit about the patient, caregiver, and provider related considerations when you're designing your program and trying to decide what population you're going to treat. And then we have a little bit of experience data on hospital at home, but also during the pandemic, we added digital remote patient monitoring and direct video conferencing and asynchronous text messaging with patients. And so I'll talk a little bit about how they perceived it during the pandemic. So the Complex Care Hub program is a hospital at home program, but it also has intensive case management. And we ended up having 3 streams of care. So an acute virtual inpatient stream, a subacute virtual inpatient stream, and now we're starting to open up an outpatient stream. And basically to decant people as they become more stable, but still require, the tying up of certain loose ends. So the basis of the program is a hospital at home. It's run by general internal medicine or family medicine hospitalist physicians who collaborate with community paramedics. And also we have nurse navigators in our program. We provide 7 days a week access to someone from the healthcare system, from the healthcare team, either by phone, by virtual visit, or by home visits. And during the week, we do clinic visits. The intensive case management is provided by our nurse navigators that are linked in with what we call transition services. And so they have access to ordering home care, ordering continuing care, so long-term care and supported living. They're able to do provider linkages, connect with community services and primary care. And then a lot of the other work that we try to do is to empower patients through education and through action plans to self-manage their chronic diseases. So as we stabilize them, we start teaching them how to manage, for example, their heart failure and an action plan for when they decompensate. And we do a lot of medication reconciliation. We try to deprescribe, particularly in our seniors, and a lot of education, at least we try, a lot of education about their medications. As I mentioned, during the pandemic, so the Complex Care Hub program in Calgary collaborated with another home-based acute care program in another city in our province called Edmonton, and we worked together to develop a provincial strategy for virtual hospital care. And with that, we obtained a grant that enabled us to acquire digital remote patient monitoring on a cloud-based platform where the patients get kits and with all the vital monitors and a tablet, and we can access their vitals through a web-based portal. And with that, for the Complex Care Hub, we were able to increase our census by 31%. And part of that was that one of our barriers before was that we used to run out of community paramedicine time. And with the digital remote patient monitoring, we were able to become kind of a hybrid model. But there was a concern, especially because our patient population tends to be elderly, that what if they don't want to use the Zoom? What if they don't want to interact virtually? So that was one of the questions that we initially had. So this is kind of what our hospital at home looks like. So before the pandemic, we didn't have the cloud-based data transfer and video conferencing. But we have a hospital-based team, and we have a clinical space where we can see people if they're decompensating or if we need to expedite investigations. And that's where our physician and our nurse navigator is based. And then our home visiting team, for the most part, comprises of community paramedics that serve as our eyes and ears. We're integrated in terms of we share the hospital electronic health record with the community paramedics so that we can write orders for them and they can carry them out in the home. And we have one source of truth. So we all document on the same, we see the same results, everything is all on the electronic health record. The addition of the digital remote patient monitoring platform, though, was independent. We haven't yet been able to integrate it with our EMR because our province is in the process of transferring to Epic, and so that will be coming in the future. And as you can see, the patients take their own vitals, send the data to the physician. The physician can either talk to them through the portal or they can send out a paramedic and then do a consultation that way. So since we started in 2018, I think this number is now higher, but we've admitted to the program over 570 patients. The median age of our patients is 71, and the Charleston Comorbidity Index, about 2/3 of them have at least a score of 2 or higher. And you can just see, over the year, like every year, we've been increasing our census, and you can see in 2020, when we added the digital remote patient monitoring, that our census increased a bit more. I think I was looking at the questions earlier, and I think someone was asking, well, where did you get your patients from? Did you get them from the eMERGE? Did you get them from the wards? And you can see here, so the blue lines are the inpatient wards. We've found that it's easier to pick patients off of the inpatient wards because in the eMERGE, the timing of when the patients are ready, when they've been worked up enough by the eMERGE doctors, is around 2 o'clock in the afternoon, and our nurses are only around till 4 or 5 in the afternoon. And because when you're selecting a patient, you need to do all the safety screens, just as Colleen was mentioning in her program, we do the same. It takes longer than just admitting them to an inpatient ward where I, as a physician, would come, do a consult, write some admission orders, and the patient would go upstairs. And so we found it sometimes easier to pick them up off the ward a day or two into their admission, but we do strive to get them out of the eMERGE. And as you can see, also from the community, and that means referrals from internal medicine clinics or from primary care. In terms of, when you're trying to decide who are your patients going to be and how are you going to get them onto your program, you need to think about things like, can your patients afford to be on the program, or what costs are they going to incur? So are you going to pay for their medications? Are they going to have to travel back to the hospital for diagnostic testing, for example? Are they going to be able to pay for parking? What if they decompensate? Are they going to have to pay for their ambulance? So in Alberta, for example, if you call an ambulance, it costs $300 for the patient. So we had to negotiate that if we called the ambulance, that would be included in the cost of our program. Other barriers to care in terms of patients. So what's the population around your hospital like? What are there going to be language barriers? Are there safety concerns in the home? So we also do a safety screen for the type of population that you're going to be caring for. So if they're vulnerable or frail elders, are there caregivers present, and is that a requirement? And what's the internet connection going to be like if you're going to be leveraging something like digital remote patient monitoring? The other thing to think about, if you do require a caregiver or family present, what's that family doing? Like, how are they doing? Are they burnt out already? Have they been caring for this person for a very long time? And then in terms of inclusion and exclusion criteria, so if we decided in our program that if people were not frail, they would have to be independent for their ADLs and IDLs. And so that would be one less barrier for us to take care of them. But we also decided that we would take people with frailty as long as they already had home care, or they would be safe at home for at least 24 to 48 hours until we could get home care into the home. And so that either requires a competent adult that's available 24/7, and that these patients are safe with respect to falls. The other thing in terms of the home environment, we also required some form of ability to communicate with them. So they need to have a working telephone, and the home environment, or at least where they're going to receive care from us, has to be safe. So there have been a couple of cases where, we didn't think that the paramedics were safe to go into a particular home. The patient felt safe, but the paramedics didn't. And so we asked the patient to go somewhere else to receive care. In terms of exclusion, so because we are dealing with a general internal medicine population, we weren't very prescriptive in terms of the inclusion, but we had a lot of exclusions for safety. So similar to Colleen's program, acute conditions that would require being in a bricks and mortar hospital, like myocardial infarction, a stroke, fractures, as acute surgical conditions, would be an exclusion for us. Also, acute psychiatric illness. So if they were having acute psychosis, we would not be able to manage that. So that would be an exclusion. We also, in our seniors population, we excluded severe delirium of unknown etiology because it's highly associated with mortality, and as well injurious and recurrent falls. The other thing that we looked at was that they have to be showing a trajectory towards improvement. So if they were unstable or worsening, even if they were stable now, that would not be a reason to take them, or sorry, it would be a reason to exclude them. And as I said, risks themselves, risks of harm to others, all of those would be exclusions. And then in terms of the living situation, we have taken a few people from long-term care, but we find that there's a really big problem in terms of medication management because there's too many cooks in the kitchen. There's the nurses in long-term care, and then there's our paramedics, and then there's the patients. And so we've only taken a handful of people from long-term care, and supported living is actually even harder to navigate. So we've been slowly working on a process for that. We haven't yet been able to provide hospital at home care to people who do not have a home, but it is a population that we are trying to think about how we could equitably give them some form of care. We do have a program here that provides palliative care in the inner city. And then again, unsafe living situation would be an exclusion. The other thing to think about is that you need to match the patients that you're going to choose with the provider's level of skill and comfort with this program. So when we started this program, the model didn't exist. And in Canada, it was considered really on the limit of what people felt comfortable with. And so I made it look a lot like what a bricks and mortar inpatient ward would look like in terms of what the electronic health record looks like. It's the same one and all of those things. But we did also look at the types of patients that our physicians would feel comfortable taking care of. And we tried as much as possible to replicate the processes so that they would feel as comfortable as possible and would worry more about caring for the patient than all of the logistics that come along with providing hospital at home care. The other thing that we've done from a medical legal standpoint is that patients have to provide consent to being on our program. So when they come through the doors of the hospital, they already provide consent to receive care, but we have them provide an extra consent. We give them it's like a 5-page informed consent sort of document to read through, and then they have to provide us with informed consent to be on our program. And then this also, when they do give that consent, part of that are the responsibilities that they have as patients. Just in terms of patients' experience, patients really liked the use of telehealth. They felt that it improved their access to healthcare services, and particularly during the pandemic, helped them to avoid being exposed to communicable diseases or COVID. It also helped them get out of the hospital earlier, which in Canada, people are really worried about length of stay because we are a single provider, and we're really worried about our healthcare system sustainability. We asked them through some interviews and surveys what's working well and what's not working well in terms of the use of the hospital at home, and particularly with the telehealth. And patients and caregivers for the most part felt that the visits with the physicians and the community paramedics were frequent enough, in-depth enough, that they felt well enough cared for and felt in general empowered and to get this care at home and to support their loved ones from the caregiver perspective. As I mentioned, they were really happy about saving hospital beds for people who were more sick or sicker than them, and to lower the cost of care. And the caregivers in particular felt that it saved them time because they didn't have to travel to the hospital to visit, that they were able to bring the rest of the family around the patient, because especially during the pandemic, there was a limit on visitors in hospital. And they just felt that it was less stressful for them. In terms of opportunities for improvement, some of the patients had difficulty navigating the technology. So we have an automated phone line, or even the oxygen. Some people felt that the oxygen, it's very rare, but some of them felt that they need more instructions on how to manage their oxygen. And in terms of communication and continuity, so we have a rotation of physicians. And so for some patients, that's not enough continuity of care for them. The caregivers and the patients both felt that the travel to hospital when they had to come was burdensome, and that the communication could be even further improved. The providers kind of reflected the same thing. So they felt, these are the patients, they felt more involved in their care with the digital remote patient monitoring, and felt that the quality of care was better or much better for the most part by adding this technology. take-home messages. So when you design when designing your program and when selecting your patient population, what we did is we put the patient at the center of our program design and did like a patient journey. We mapped what their journey would be like through the healthcare system, and then decided where their touch points would be and who would be the providers that we would need. It's important also to consider stresses on patients and their providers, like costs and travel and all of those things, and language barriers, and to leverage the technology that your patient population can handle and that enhances the care that you're able to provide. And continually improve processes and communications between your patients and providers, between your providers and their providers. And that's it, I think, for me. I just want to acknowledge this was a group effort, so there's a lot of stakeholders in Alberta Health Services that helped to make this a reality.
Great. Thank you both. We've had a robust Q&A session, and I've tried to select and summarize, many of these questions, to try to answer as many as we can in the remaining minutes that we have. So, Colleen and Michelle, there were a number of questions about the referral process and the structures that you have created in both of your organizations. Colleen, there were questions about what exactly is this physician referral line? Where does it sit? This hospital at home quarterback, where does this person sit? Who is this person, et cetera. And similarly for you, Michelle, these are questions about the box that you had in your table about the hospital-based team and the day clinic. Where are these things? Who staffs these things? And what are they actually? So let me turn it over first. Colleen, and then I'll ask Michelle to answer that question.
Sure. It's Oz. No, I'm just kidding. No, there is a physical building that PCL, Physician Connection Line, has lived in for a couple of decades almost. But most of that work is now being done from folks' homes, believe it or not. So our quarterback, in most cases, sometimes they work from a hospital virtual room, but most of the time they are working from their own homes, as are all of our nurses and our providers, in most cases working from a home office.
Michelle?
Yep, and so for our program, we are operating out of 2 hospitals in Calgary. Each hospital has a physician and a nurse, 2 nurse navigators. And then we share the community paramedicine resource. So we have 3 trucks kind of running around the city at any given time for us. And each of the hospital sites has a clinical space where we can bring in a patient if we need to, and that allows us to access the inpatient services with the same priority. So for example, diagnostic imaging I can get with the same priority as outpatient, because our waiting lists for outpatient are quite long here. And so that enables us to expedite their investigations.
Great. And so just to follow up on that, Colleen, because one of the questions also asked that if some of this infrastructure was virtual, who's actually laying eyes on the patient and seeing the patient, for that determination of appropriateness?
Yeah,
make sure
great
you're
question.
not taking somebody home who's too sick.
Right. So part of it's our hospitalist group that is the core of our provider team. So those are the inpatient folks that do our H&P and all of that assessment for clinical appropriateness, some of the social determinant stuff, but we use largely nursing for that. But yeah, part of that same team. And those hospitalists also rotate through our program, most of them from the virtual aspect. So it's one group really of providers, but I guess the rounding that happens daily, that's done virtually.
Okay. So it is the physician, the PCL, physician connection line, or whatever, this quarterback, and then there are these hospitalists on the ground.
Right.
If I understand that correctly.
Right.
Okay. Which brings me to the next set of questions. We're still on the referral process, and this is to both of you again. There were a number of questions about how do you actually, find these patients? Are And our patients, physicians, and nurses just calling you, and how do you engage that process, in terms of making sure that you're getting calls for the right people. And as those of us, who have, run referral services, know that if you say no too often, people will stop calling you. So how do you handle, the no's that you invariably have to, say sometimes? So let's go to, Michelle first and then Colleen next on this one.
So this is kind of the million-dollar question for us. It's a continual process. So initially when we started the program, we went to all of the staff in Emerge, all of the staff on the wards, and I went to all the business meetings for all the physician groups that could be referral sources, and just did kind of a dog and pony show, right? And then over time, people change and then you have to do it all over again. And inevitably, we've had to say no more than we'd like. And that is, for example, for the emergency physicians that refer, that is a thorn in their side. They want to know the disposition of the patient, and we take 2 or 3 hours to make sure they're safe, that they're not going to fall, that they have their oxygen, that home care is, we do everything you would do in the first week in that initial meeting, right? And I think people don't realize how much we actually have to do to make sure that we're taking the safe patient. So that's an ongoing problem. And what I find is I continually re-engage the stakeholders that are referring. At the beginning, we used to screen all the patients in the Emerge ourselves. And what I do now is if I'm getting enough consults, then I don't worry about it. But if I don't have enough consults and I want more patients, then I'll walk around the Emerge and I'll walk around the wards and I'll talk to the charge nurses and I'll talk to the physicians, like when I'm on the service, and that's how I'll generate business. But it's usually what we say is that it has to be a referral from a physician. So the nurses can suggest it. So I'll talk to the charge nurses and then I'll suggest to them. One of the issues that we've had is that this is really a hospitalist level acuity, right? And we're mostly general internists. And so we've had to really work with our hospitalist colleagues who have other incentives for either referring or not referring patients. And so we've really had to understand the mentality of why they do or do not refer patients to us.
Colleen?
Yet similarly, we were very intentional around building this around hospital medicine for that very reason. Now, I will say through COVID, we had a number of IM and FM ambulatory providers who helped us and were amazing. In fact, we've converted a couple of them to the hospitalist team, as a matter of fact. But as Michelle says, it has to come from a physician. We do use nurses and navigators and some of those folks I talked about to tee it up, to say, hey, I've been taking care of Mrs. Smith today. She would be, I think, a perfect candidate. Through those IDRs or interdisciplinary rounds, it's teeing up patients. But at the end of the day, there has to be a provider-provider conversation. And that's what we use that physician connection line for. So the physician that wants to send the patient and our hospitalist, hospital at home physician have a conversation. Mobile medicine is on that conversation as well, and the quarterback. So it really is more than a 360 view of appropriateness for this patient. And sometimes we do have to say no. And when we do, we worry that may be the last referral we get, but patient safety trumps everything. And sometimes it's just not the right referral.
So
We have tried a few different, I'll tell you what hasn't worked. So we tried allowing the community paramedics to refer people that they see outside of our program, and that has not worked. Mm-hmm. Even though we triangulated it with their family doctor, it's just not worked. Because either they're too acute or they're not acute enough, or I don't know exactly why. And then the other thing that we've tried is having the emergency room physicians, when they have someone who they know would potentially be appropriate, to refer them to us and we see them the next day, like have slots in our clinic to have these patients come back and then we can see them. That gave us a few patients, but there've been a few where we've had to refer them urgently back to the hospital or that they were just not appropriate. But the other thing that we have done with some variable success has been to choose, for example, COVID or CHF, and to have a campaign where we say, refer us all your CHF patients, or refer us here's a pathway for COVID. And so again, it's a trickle. Like it doesn't vastly increase our census, but it does help a little bit.
So just a quick number from both of you. what is the ratio of yes and no, that you have, in steady state?
Yeah, I think for us, the last time we looked, it was about a little over 50% that we say yes. We're trying to make it better, to be honest, but we have to say no often because people don't realize what we can and can't do.
Okay, and Colleen?
Yeah, I don't know the number, and I'll be honest to say, I don't know that we track it in any official way. I think we say yes far more often than no because we've hyper-trained folks to know what that eligibility criteria is. And then, of course, we've got our hospitalists in the house who can physically assess before some of that even goes by. I know for certain it's far more yes. I'm going to guess 80% of the time it's a yes.
Okay, great. Now, we only have a few more minutes left, so I'm going to ask a question to both of you about what some call leveling in terms of determining, that they need to be in the hospital. Colleen, you've described, really a continuum, of patients, and services that have been developed around COVID. And Michelle, you've described, a continuum that you throw into the complex care hub. And my guess is that within these continuums, in both cases, there are some who meet criteria to be hospitalized and some who don't. But I don't think that, that this was perhaps, clear, from the presentations. So let me give you, a few minutes, to describe, how you determine need for hospitalization within your continuums.
Yeah, so we go through leveling just as if the patient was being admitted to one of the wards. We've got a team of folks, they're nurses actually, who within 12 to 24 hours evaluate every single patient for appropriateness for admission. So we treat them exactly the same. Occasionally they were admitted as an inpatient and need to go to OBS or vice versa, need to be upgraded to inpatient, but we do that and we do it continually throughout the stay to assure that they're still appropriately inpatient.
Michelle?
So I would say one of the things that I've been advocating for in the two hospitals and actually in our city is that we look at every patient in the hospital and do exactly that, the leveling. I'm getting closer to having them understand that, just like you would not keep someone in ICU if they didn't need to be there anymore, you should also not keep them in a bricks and mortar hospital if you have a hospital at home. What we do is when we screen patients, like for example, when we screen all the eMERIT patients, we look to see whether or not what their level of acuity is and whether or not they would fit our criteria. So right now it's more us case finding, but I am sort of slowly getting, the directors of the hospital to understand that we need to do a more sort of broad assessment of the entire hospital population, and exactly this, to keep looking at who can move where, rather than, because I think that the mentality right now is that the patient belongs to the physician, right? That the physician has ownership over that patient. But really, if you look at it from a system perspective, the patient should move to where their care is more appropriate. Once they reach the hospital at home program, we are continually looking at the level of acuity of our patients, and then we stratify them based on whether they're acute, subacute, or if we can discharge them to either back to their family doc or if they need us for a little bit longer in an outpatient setting.
Thank you both, for your presentations. I've learned a lot, and I'm sure, that our audience today has as well. And I've tried to, hopefully we've been able to address many of the questions, from our audience, but we can also try to get back to some of them, offline as well. So before we close, let me take you through a couple of slides. This is the website for our Hospital Home Users Group, as well as our technical assistance. We've provided a number of things on that website, including an annotated process, an annotated CMS waiver process. We are at the top of the hour. Please, take the opportunity to join the Hospital at Home Users Group if you're interested. And please remember, to answer the questionnaire that will pop up at the end of this webinar. Please provide us, your feedback. It has been very helpful in terms of structuring this entire series as well as topics for future webinars. Thank you again, to Michelle, for presenting, and thank you all for staying with us through this hour.